Thank you for taking the time to share with us. Thank you. Do we have the issues with Mr. Mitchell worked out online? Okay, Mr. Mitchell, if you would start your presentation from the beginning, and because I think it's important that we take it sequentially in the way you want to present it. Go ahead, sir.
Thank you so much. I appreciate all your patience with me. So I was looking forward to being with you in person today. Mother Nature had other plans, but thank you so much for your accommodation. So once the federal government repealed its mandate in the 1980s, and that was a bipartisan bill, since then, some 15 states have eliminated their con programs, and several others have pared theirs back, and that includes some that are doing so right as we speak, including Florida, Montana, and Tennessee. This is important because now nearly 40% of Americans live in a state with no certificate of need requirement for healthcare services or technologies. These are a diverse set of high income, low income, urban, rural, coastal, and intercontinental states. For the last several decades, health economists have tracked outcomes in these non-con states, comparing them with outcomes in states like South Carolina that continue to require certificate of need. These peer-reviewed studies compare these outcomes while controlling for both observable and unobservable factors that might affect the outcomes. So in the written testimony that you have before you, I've summarized some of this economic literature on certificate of need, and I've also presented some estimates of access, cost, and quality outcomes that we think would prevail in a South Carolina without certificate of need. That's basically just drawing from the experiences of other states. These findings point to a clear pattern. Certificate of need laws do not achieve the laudable goals of their advocates. In fact, on many dimensions, they seem to make matters worse. In those states that have repealed their certificate of need laws, patients enjoy 1, greater access to care, 2, higher quality of care, and 3, lower cost care. So first on access, this is the one where the data really are overwhelming. In non-certificate of need states and controlling for other factors, there are more hospitals per capita, about 30% more. There are more ambulatory surgery centers per capita, about 14% more. By the way, this isn't particularly surprising. Con restricts supply, so you would expect without con, there would be greater supply. There are more rural hospitals and more rural ambulatory surgery centers. Both of those figures are comparable, about 30% and 14% respectively. There are more hospital beds in non-con states, and we find that there were more beds available during the pandemic in these non-con states. There are more dialysis clinics, more hospice care facilities, more imaging services. Of particular importance for rural states, patients don't have to travel as far to get care in non-con states, nor are they as likely to leave their counties for care in non-con states. There are also smaller disparities in the provision of care to communities of color in these non-con states than in certificate of need states like South Carolina. Second, on quality. On average, patients do tend to receive higher quality care in non-con states. These numbers are not huge, I should note, but they are consistently found across a number of different categories. So for example, one study of nursing home cons found that nursing home patients were less likely to be physically restrained and were likely to benefit from higher RN staffing ratios in non-con states. A separate study found that patients in non-con states experienced lower mortality rates following heart attack, heart failure, and pneumonia, and lower readmission rates following heart attack and heart failure. That patients were less likely to die from post-surgery complications in these non-con states, and that patients were more likely to give their hospitals top ratings in these non-con states. Yet another study found that all-cause mortality is about 5% lower 5 years after certificate of need repeal. Third, cost. Patients spend less in non-con states relative to con states. They spend less, payers spend less in non-con states relative to con states. These payers spend less both per procedure as well as per patient or per citizen. So in summary, we don't have to speculate about what happens without certificate of need. We can compare outcomes in con and non-con states. We can control for possibly confounding factors, demographics, age, economics, and there's abundant evidence that in a South Carolina without certificate of need, patients would enjoy greater access to higher quality and lower cost care. Thank you so much for the opportunity to chat with you and your patience with me today. I look forward to taking any questions you might have.
Senator from Anderson.
So in your opinion, how do the hospitals perhaps lose the patients to the new centers that are cherry picking, how are they staying afloat then? What's your opinion about
Well, so that's a great question. So, one thing to note, of course, is overall trends are that hospitals on a per capita basis are disappearing around the country. They're either flat out disappearing or more likely they're just not keeping up with population. And that is true in both con and non-con states. What seems to be the case, though, is that they seem to be disappearing at a greater clip in certificate of need states. And the basic reason is certificate of need is a costly barrier to entry. So it makes it difficult for even the protected hospitals. Over the long run, they don't necessarily benefit because it's costly to have to deal with the litigation and the process of having to ask for a certificate of need. Now they may differentially benefit, but because large hospital systems tend to find it easier to navigate the con process than smaller ones, but over time they may not benefit actually.
Other questions for Mr. Mitchell and Senator Kimpson? Can you hear us?
I can hear you, but can you hear me?
I can hear you now. I'm sorry that you were having difficulties earlier. I should have checked in with you earlier. You have questions for Mr. Mitchell?
I'm curious as to this question with respect to the market. What I heard the last person testifying say that you can't compare this to a purely market approach. Because unlike the pure market, these services it's a unique space. I'm curious as to what your response to that is.
So I think that's a great question, Senator. If you go back to the 1974 statute, at the very beginning, Congress basically made that argument. They said, healthcare is different in large part because the government has gotten so involved in healthcare. We need this further involvement in order to counteract some of the previous involvement. So I think it's tempting to think of markets as either all free market or some alternative, all socialist or something. But in reality, we try to teach our students to think on the margin. And I think it's helpful to think on the margin here. Healthcare is not a free market by any means. It's probably less free than most other markets in the United States, maybe right up there with energy. However, if you think on the margin, what this does is it makes it a little bit more competitive. There's still all sorts of interventions in the market, and those could be talked about at another time. Some of those make sense, some of them don't. But on this one, I would just think of it as a marginal public policy that makes healthcare less competitive. And what we find is that comparing outcomes in the more competitive markets that have repealed certificate of need laws with outcomes in the less competitive markets that have not, the markets actually behave exactly as economic theory would predict. Costs seem to be lower, quality seems to be higher, and access seems to be higher in those more competitive markets without this barrier to entry.
Thank you.
Other questions for Mr. Mitchell? Thank you so much for hanging in there with us with the technical problems and sharing your thoughts.
Thank you.
And I'm a great admirer of your entire department up there, the economists and everything at George Mason. You guys do a fantastic job. So
thank you so much.